Hi. Today we're going to talk about some concepts in sedation. Um, when we think about sedation, we have to think about it in the terms of three intermingling circles. We have to think about it as pain, analgesia, and psychomimetic medication, or pain, analgesia, and delirium. Pain, analgesia, and delirium. This is obviously sedation that is used for patients in the ICU. Why is it important to talk about it in three different circles like this? Because we misdiagnose the cause for sedation, for agitation all the time. Not every agitated patient needs Ativan. Not every agitated patient needs Haldol or Seroquel or fentanyl or Dilaudid. We mess it up all the time. So we have to think about it that way. Most of the patients, these circles intermingle together, like inside each other. A small percentage of patients have two things together, like pain and anxiety together, or they have delirium and pain together, or the three of them together, which is very rare. Most patients have one of them only, and that's the driver for the agitation. I'll give you an example. A couple of examples. For example, somebody who's demented, who is not communicative, hasn't been communicative for years. Now, we took him to the OR and we cut his leg. Will this patient, after he comes to the ICU, raise his hand and say, "Doctor, I have pain in my leg," and then go back to become agitated again and non-communicative again? No, he will be agitated. He will be like a child. He can't communicate. He wants to tell us something, but he doesn't understand what he wants to tell us, and doesn't communicate with us. So what he's gonna do is gonna start, pulling on his leg, and maybe trying to, jump off the bed. Maybe if I pull on this central line, maybe the pain is gonna be better. Maybe if I pull on the endotracheal tube, maybe the pain is gonna go away. He doesn't know. This patient, if you give him both loads of Ativan, both loads of Haldol, that's not the answer. You're gonna overdose him on those medications, but at the same time, you're not gonna treat the condition. Whereas, if you give him a small dose of analgesic, that will result in his agitation to subside. Similarly, if a patient is seeing ghosts in a room, he's delirious, he's seeing dead people, he's seeing ghosts, he's seeing whatever. So he is so anxious, he's screaming, and he's sweaty, and he is diaphoretic, and he is tachycardic and tachypnic, and have all the signs and symptoms of anxiety. The treatment for this patient is not Ativan, because the inciting factor is not anxiety. The inciting factor is delirium. So when the patient is delirious, we treat him with psychomimetic medication like Haldol. So if you give him all the Ativan that you have, the patient will go to sleep, but at the same time, still see the ghosts, still see the dead people, and still be agitated. So he may be asleep, but he'll be agitated. So you need higher doses of Ativan to control his hemodynamics and control his movements and all of these things. Whereas somebody can tell you, "I am anxious. I feel like I'm gonna die. My name is so-and-so. I know where I am. I know who's the president. I know that I had surgery. I know this. I know that. I'm fully with it, but I have a feeling of impending doom." That's the patient that requires Ativan. The problem that happens is anecdotes. And it's anecdotes on the institutional level, on the individual provider level, and on the patient level. We've all heard sign out between residents and nurses that says, "The patient is seeing ghosts in the room. We tried 0.5 milligram of Haldol because he's old, so we have to use a small dose. It didn't work. So we tried 2 milligram of Dilaudid, and it worked. That's a fallacy. Because Dilaudid didn't work. Dilaudid just put him to sleep. Why is this? Are these fallacies and idiosyncrasies and misconceptions developed? Because all of those medications, whether it's narcotics for pain or opioids for pain, whether it's psychomimetics for delirium, whether it's benzos for anxiety, when you give more of those, the patient sleeps. It reaches hypnosis. So it puts the patient to sleep, but it doesn't treat the condition. So that's why you overdose somebody on Dilaudid 2 milligram and you think that Dilaudid works for ghosts. Dilaudid doesn't work for ghosts. Hence all of these misconceptions. Where did we know that? Or where was that very obvious and made a mark on the medical community? In cardiac surgery, cardiac anesthesia. For the longest time, since the beginning of cardiac anesthesia till probably 2000, the year 2000, which is about 50 years, the induction of cardiac anesthesia was thought to be using 300 microgram, roughly, of sufentanil plus 10 milligram of vecuronium. 300 mics of sufentanil equal, just for people who don't know sufentanil, is equal to 3,000 micrograms of fentanyl. That's a huge amount of fentanyl. The typical dose is 25 to 50 microgram. That's a 3,000 microgram of fentanyl. And the only reason we don't use fentanyl is that it's just going to be a huge syringe. So that's why we use sufentanil, which is 10 times as strong as fentanyl. Also, we're using vecuronium, so patients don't, that's a muscle relaxant, so patient doesn't move. What's missing from this combination here? This combination, because it's so much narcotics, number one, why is it preferred? It's preferred because it's hemodynamically stable. So for cardiac patients, it's better to use a hemodynamically stable. We don't want to use gas anesthesia. We don't want to use propofol, for example. These things will drop the blood pressure. We don't want that to happen for cardiac patients. So what we use a stable anesthetic. It is indeed a stable anesthetic, but and it puts the patient to sleep through induction of anesthesia, through lines, through sternotomy, through pump, off pump, extubation, or even going to the recovery room, and sometimes even up to the for a few hours in the ICU until the patient is extubated. All of that is still sedated. The patient is still asleep. Sedated is not the right word. Sleep, hypnotic, from the dose of sufentanil that he got. But what's missing here? What's missing here is amnesia. Where is the amnestics? That's why cardiac surgery over the years had 1 to 5% incidence of recall under anesthesia, which is a disaster. It's not inexcusable. One of the highest types of special subspecialties in anesthesia where it has the highest recall was cardiac anesthesia. Because of that. That number should have been 100%, but for the grace of God, two things happened. Number one, scopolamine IV was being given at that time, and we would make the patient amnestic, but also put the patient in a delirious state for about a week. So that prevented some of the recalls. In some practices, they were giving scopolamine. Not everybody was giving scopolamine. And also, the patients themselves, sometimes they're just so grateful for the surgeon and anesthesiologist. They don't want to bother them. Sometimes they don't know if they heard that in the recovery room or if they heard what they heard in the OR. And most of the time, they also can't repeat what we say in the OR. If we are professional and talking about instruments, they're not going to be able to repeat the Bakey, for example, or any type of instrument that we use. Because they just will forget. So these things prevented that number of recall to be 100%, but I can guarantee you that at least more than 50% of people actually heard things during the OR. when you use this type of anesthesia. But if you are a malpractice lawyer wants, for example, to defend the physician and to discredit the patient, you might want to set a trap for them. You know what the trap is? And how much pain did you have? And the patient maybe will say, a lot of pain, and that means he's lying. There is no pain. It's impossible to have pain with 300 mics of sufentanil. So the patient will say, I heard them opening my sternum and I wanted to say something, but I couldn't and I was terrified. That's all legitimate. But he can't say I have pain. There's no pain, right? So I hope we got that it's compartmentalized, or try to compartmentalize the thinking about sedation or the use of sedatives, pain and anxiety and delirium. Thank you.